By introducing myself. My name is Joan Bachorf. I'm here at the University of British Columbia's Okanagan campus. And as you can see, I'm not on campus today, but joining from my home, as most of us are on our campus. But before we begin today, I'd like to begin by acknowledging that the land on which we gather, both in our community and on campus, is the traditional unceded territory of the Syilx Okanagan Nation and their people. We are delighted to welcome you here today to join us with this webinar that we are doing in conjunction with the Institute for Healthy Living and Chronic Disease Prevention here at UBC Okanagan and our partners, the North Okanagan Hospice Society. We're also delighted to have a speaker with us today who will present the webinar, and there will be time for questions and comments at the end. And we'll be inviting you to put those comments in your chat box at the bottom of your screen, and we'll read them out so that our speaker can address those comments and questions. But before I begin, before we introduce our speaker, I want to introduce Clara Dick, who's the Education and Resource Leader at North Okanagan Hospice Society, who's going to introduce our speaker.
Right. Thanks, Joan. As you can see, I am at work. I'm needing to be in-house to support our care team leader and our residents here. Joan, we're so happy. North Okanagan Hospice Society is so happy to have an ongoing relationship with UBC Okanagan Institute for Healthy Living and Chronic Disease Prevention. It's our pleasure to introduce Dawn Guthrie, PhD professor. She's with the Department of Kinesiology and Physical Education, the Department of Health Sciences at Wilfred Laurier University. Dawn will be presenting today, assessing the quality of community-based palliative care, perspectives from families, decision makers, and researchers. Dawn, I'll turn it over to you.
Okay, thank you very much. It's absolutely my pleasure to be here, and I want to start by thanking the Institute for Healthy Living and Chronic Disease Prevention and the North Okanagan Hospice Society, and Clara and Jaquetta for getting everything organized today. So as Clara mentioned, I'm at Wilfred Laurier University, which is in Waterloo, Ontario. I'm also an interRAI fellow, and if you don't know what interRAI is, hang tight. I'm going to talk about that in a couple of minutes. I also want to start by acknowledging that the majority of the funding for this project came from the Canadian Institutes of Health Research, or CIHR, which is our national funding organization in Canada for healthcare and health services research. And also some money for the project came from the Canadian Centre for Applied Research in Cancer Control, or ARC. So I want to also acknowledge the team. This is probably a bit too small for you to read, everyone, and that's okay. What I want to point out mostly is that this is a big group of people. It's an exceptional team of people from across Canada. You will see there are people from BC, from Ontario, from Saskatchewan, from Alberta, and also some researchers from outside Canada, from Belgium and from the US. So when we started this project and we're looking for funding, we purposefully set out to have a team of people from across Canada. We really wanted to ensure that to understand what we should measure and what people thought was important in terms of quality in palliative care, that we talked to a lot of people in a broad sort of group of people. And I've been exceptionally humbled by how generous everyone has been in agreeing to join me on the project. So the main goal of this project is really to develop and test a set of quality indicators for palliative care in the community. And the project is 3 years in total. We are actually just starting year 3 on April 1st. And I'm going to talk mostly about the first 3 objectives. And I'll go through each of these in sequence and tell you a little bit about how did we go about trying to have success for each objective, and a little bit about what we found. I'm not going to talk about objective 4, which you can see is about the whole risk adjustment piece. Not that it's not important, but literally we haven't done anything on this yet. So I don't really have anything to talk about except to tell you that it's coming. It is something that we're going to do down the road, but we're not there yet. But first, I want to take a little bit of a detour, as promised, to talk a little bit about interRAI. And interRAI is the name of an international nonprofit group. There's about 100 of us from 35 different countries around the world. And interRAI mostly creates and tests standardized assessment tools and various applications that come from those assessments. One of which is quality indicators. I've been an interRAI fellow for about 3 years. I've been working with interRAI data since 1999 when I started my PhD. So I've been working with this group and these data for quite a while. And I'll talk also a little bit about what we have in terms of Canada. So just at a glance, showing all the different countries that are involved in interRAI. Some of these countries might have only 1 or 2 people that are involved with the group, or there might be quite a number of people, like in Canada, where we have about 18 interRAI fellows in Canada right now. I also want to do a little bit of background in terms of these interRAI assessments, just in case you're not familiar with them. And there's a lot of these. In fact, I can't even keep up with all of the interRAI assessments that are coming out. There's dozens of them. But I thought, given the topic today, we'd talk a little bit about the interRAI palliative care assessment, or you'll sometimes see it called the IPC for short. And this is a little screenshot of the front cover of the manual. So these assessments are copyrighted, which means I'm sorry, but I can't share them with you. They are copyrighted by interRAI, and there's a couple ways you can get a hold of it. So if you want to see the assessment tool, there are a few pages online through the interRAI website. That's just a handful of pages to show you some of the content. You can't download it or copy it, but you can just sort of browse through it. Or the other option is that you purchase a manual, which is that's the graphic that I'm showing there. So this assessment has about 250 items. It has basically all the key questions and domains to give you a good snapshot of that person, how they're doing, and a little bit about their informal caregivers as well. So as I mentioned, there's a lot of interRAI tools. This one in particular has a lot of overlap with the home care instrument. About 50% actually of the items within the palliative care tool from interRAI are the same as on the home care assessment. And then interRAI has assessment tools for long-term care, for inpatient mental health, for people with intellectual disabilities, hospitals, community mental health. There's quite a lot of assessments. So also just to give you a bit of a snapshot of, well, what kind of data do we have in Canada? Actually, we have a lot of interRAI data in Canada. The first row of this table is just talking about the palliative care instrument. So that's the one I was talking about at first. It's only really being used in Ontario right now. And it's being used for clients who are getting palliative home care services. There are little pockets of groups using the palliative care instrument in other parts of Canada, but not in any substantial kind of way. And we have about 120,000 assessments as of March 2018, which means we've got more than that, but that's the most recent numbers I have on hand. And then if you look at the home care tool, we have a lot of home care data from all parts, or almost all parts of Canada, with the vast majority of these assessments coming from Ontario, about 2.6 million assessments. So in Ontario, for example, everybody who's getting home care in the province and they think the person's going to need about 60 days of home care. They will get one of these interRAI assessments. All of that electronic information is all captured on a laptop in the person's home, and then it is shared with the folks at the University of Waterloo, which is down the street from where I work, where all of these electronic data reside on a server and are accessible to people who are part of the interRAI group. So we've got lots and lots of data to use for this project. I also want to do a little bit of background into quality indicators. So these are quantitative measures. We often report them as a percent or a rate, and they are meant to give us an idea or a sense of how frequent an issue or a symptom or a problem, how often is this happening? How many people and how frequent is it? I like to think of them sort of like the check engine light in your car. If you're like me, you will never see me pulled over by the side of the road with the hood up of my car because the check engine light came on. I have no idea what to do. There'd be no point in popping the hood and looking at it because I don't know what to do. So the check engine light tells me there is something wrong, there is an issue, I need to deal with it. In fact, I need to get the car probably into the garage and let them figure it out. Quality indicators are much like that. They're a flag, they're an indicator, but they can't tell you for sure that a place is doing a good job or a bad job. They literally are there to just flag issues, and then as an organization, it would be your job to look into it a bit further and find out, well, why is our rate as high as it is? And why is it maybe different from what it was last year? And do we have some understanding of what's happening? The other thing you might use a set of quality indicators for is to track change over time. So if as a group you decided that you wanted to address a particular issue in your home care program, in your health region, within your hospital, you could put some intervention in place or a program or do something different as part of quality improvement. And then you could use the QIs over time to look and see, okay, did we see a change? We made some changes. We're hoping to improve quality of care. Do those indicators give us a sense of that improvement or not? And then we can regroup and decide what's next. So how do we actually measure these things? So as I said, they're usually shown as a rate or a percent. So we have a numerator and a denominator. And I just picked an example that would be relevant here. Let's say we had a quality indicator for intense daily pain. The top part, the numerator, would be a count using the data that we have. So you wouldn't do this by hand. You would have the electronic information, and you would count up, well, how many people are experiencing daily pain that's intense? They would rate it as intense. And then we divide that number by the population of interest. So who is this population? It might be everyone getting services in the last quarter. It could be a specific health region. It could be a province. So you'd have to think about that ahead of time and decide what is the group of interest. But these quality indicators are always measured for a group of people. At the population level, we do not use these to look at quality for a person. We always take all of the data and sort of roll it up at the population level. So the first objective was really to gather opinions from a wide group of different stakeholders on what they think we should be capturing. Right now in Canada, we do not have a set of kind of standardized, valid quality indicators for palliative care. So we are really sort of starting from scratch. So one of the first things we did was we held a workshop in Toronto, not quite 2 years ago, with 30 people from the province. And I'll talk a little bit about what we heard from people in that. And then we also did interviews. We have done 9 interviews with caregivers and interviews and focus groups with 11 decision makers from all parts of Canada. So all of the different sites that are participating in our project are represented within that group of 20 people. What you don't see here, which was unfortunate, we weren't able to get more than one patient. We did try. We tried very hard, and I'm very grateful for all of the different sites in Alberta and BC, Ontario, Yukon, Nova Scotia. They all tried very hard. But I think to some degree, it just reflects that when people are very ill and dealing with serious health issues and dying, being part of a research study and doing an interview isn't really at the top of their priority list. So we did try, but we weren't successful. So this is just a little bit of a summary of some of what we heard from the workshop. So what we did during the workshop, we had 30 people. We broke people into small groups, and they did brainstorming. And in this particular part of the brainstorming, we said, what do you think we should measure when it comes to palliative care in the home? And they talked about a number of different things shown here in the different colored circles. So the colored circles are just sort of a way of summarizing what did people talk about. So they talked about the caregiver, supports for the caregiver to make sure that they don't become too burdened or feel distressed. They talked about symptom management. You've got to capture things around pain and pressure ulcers and anxiety. But they also talked about documentation, understanding where the person wants to die, and spiritual care, and so on. So given the time that I have and the fact that I'm only giving you a little high level of a lot of pieces of the project, I'll just mention I do have a summary report that we did at the end of this workshop, which I have as a PDF, which I'm happy to share if anybody would like to see it. That gives you a little bit more detail about all of what we heard. We also did a number of interviews and focus groups, and we're in the process of analyzing those data. So this is what we would consider more qualitative research. All of the interviews and the focus groups were transcribed verbatim. In other words, we transcribed them exactly as the person said it. So I have a team of research assistants, most of them graduate students, and they listened to the interview, and then they typed out literally word for word what the person said. And some of these documents are 25, 30 pages. Some of them are even longer. The interviews themselves were usually around an hour to an hour and a half. Then within our team, we had a smaller group of people with qualitative training and background. And they reviewed all of the documents separately. So each person went away and read them. And then they started to make some notes about, well, what are the main themes or the patterns that are coming out? What do I think I'm hearing people talking about? And I am sort of simplifying this process, which is quite labor intensive, but these are the basic steps. Then the team, we got together and discussed as a group, what are we hearing? Where are there some similarities? Are there differences? Is it that one person thinks this is something important people are talking about? Do others in the group agree with that, or do they see things differently? And you go through this kind of back and forth process of trying to make sense of everything people are talking about. And then as it's starting to come to an end, we are actually probably going to wrap this up in the next month or so. You take all of these ideas and you group them into sort of major buckets, which we often call themes and sub-themes. And so I'm going to be able to just touch a little bit on what we were hearing from the interviews. We are actually going to write this piece up as a separate scientific journal article. There's so much really fantastic, really rich information in there. And I do want to point out that this is not complete. So the results I'm showing you today are very preliminary, but we're fairly confident, since we're almost at the end, that these are major themes that people have been talking about. So on the left-hand side there, you see our 4 major themes, and within each of those are sub-themes. So I'm just going to touch on 2 of them. Under the Caregiver Anchor, I'm going to talk about part of the team. These are quotes where people talked about something related to the team. And under Bewildering System, which is the name we've given to that theme, I'm going to talk about theory versus delivery. And as you can see just from the table, unfortunately, I'm just not able to talk about a lot of this, but we certainly have a lot of information, really good, really interesting information here. So in terms of the Caregiver Anchor, what we've defined this as is the caregiver is essential for keeping the patient, quote, anchored within the healthcare system. So without the caregiver as an anchor, the patient would get lost and his or her needs would not be met. The caregiver is acting as an advocate. So when people were talking about these kinds of things, we put them under that heading of Caregiver Anchor. And I have a couple of quotes here I want to share with you. So Sam said, as much as he was having less of an anchor of life, the caregiver really then becomes the only anchor. And Leah shared, so I think somebody needs to help support the patient during those gaps, right? During those times when they're waiting for the people to come and talk with them, when they're trying to understand what's going to happen during the whole end of life process and whose role this is. It gets kind of confusing. And this sort of takes us into the bewildering system theme, which for caregivers, they talked about the healthcare system being bewildering to them. It was not user-friendly. It did not meet all the needs of the patient or the caregiver. Caregivers talked about being unsure of how to navigate the system and experience a lot of stress in that caregiving role. So in this case, Alice said, I said to her, you have a palliative care physician, but I felt like I was fighting with everybody to get a palliative care physician on. And yeah, it was a strange experience. I mean, I knew he was dying, but it was almost like nobody else could acknowledge he was dying. It was very strange. And Joan said, I should have raised a stink. I was advocating, but I wasn't. With the lack of information, I wasn't getting anywhere. The system was ruling. So a lot of talk about frustration with the system, not understanding how to navigate the system. I want to point out that we also had lots of very positive experiences with the system. I know what I'm presenting here today, when I was looking back on the slides, I realized it sounds quite negative. And there were a lot of these concerns expressed, which is why these have come out as major themes. But I did want to also just mention that there were people who had extremely positive experiences with the palliative care team, and they talked about that as well. I just don't have time today to go into too much of that. So looking on at the next objective, so what we did to move on is we took all of that information that we heard from the workshop, from talking to the caregivers, from talking to the decision makers, and then we started to create quality indicators. So just as I mentioned at the beginning, defining that numerator, defining the denominator, so long as we had data. So the whole thing of this project really rests on the data that we have from interRAI, from either the home care instrument or the palliative care instrument. And some things people talked about, we just can't measure. The reality is, even with 250 or 300 items, some people talked about things like communication. They talked about not knowing sometimes what the role of different people on the team were, and being frustrated that the members of the team maybe didn't seem to be communicating with them or amongst themselves very well. We just can't measure that with some of the data that we have within interRAI. So that's one of the limitations of what we're doing, is we're using the existing electronic information that's there, If we don't have items to capture those things, we'll make sure and report on that to let people know these are important things as well, but we just can't capture them with the data that we have. So the next step was to get feedback from a panel of experts on this list of preliminary QIs. This was objective number 2. So we developed 27 quality indicators. We had a team of 27 experts. Just happens that we had 27 QIs and 27 experts. We certainly didn't plan it. From Canada, the US, and Belgium. And we sent out a giant Excel file to all 27 experts, and we asked them to rate each of the QIs on 4 separate criteria. So number 1, validity, which is essentially, to what extent do you feel that this quality indicator actually does capture something that's important to families or patients. Number 2, just as the name implies, importance. So each expert rated the QI as whether they think it reflects an important outcome or issue for patients or caregivers. Then they rated each QI on the evidence of improved outcomes. So in other words, is there evidence that if you improve the indicator, so things seem to get better in terms of the rate of this thing, does that really have a positive effect at the end of the day for an individual? And number 4, as the name implies, usability. So how easy is it to interpret this QI? Do I really understand kind of what it is, what it's measuring, and can it be used to improve care delivery? So I'm not going to expect you to do the math in your head, because I certainly couldn't, but if you take the 27 experts and you take the 27 quality indicators, and then you multiply that as well by the 4 different criteria, you get 2,900 pieces of information. So it's just this first review of the panel, the QI for the QIs, just ended about a month and a half ago. So we're not finished the analysis yet. So again, my apologies that I have to keep giving you, sort of hints of where we're headed, but no final things until the project's done. So we're still in the process of analyzing all that information. What I can tell you is there's sort of a clear pattern coming out. Across the 27 QIs, there are 20 for which we have quite good consensus, in the sense that those 27 experts seem to all be on the same page that this is an important quality indicator, and yes, we should keep it. For 7 of them, it's not so clear. There's a bit of a mixture of people's opinions. So I'm not going to show you all 20, but just to give you a bit of an idea, the 20 indicators that the experts think we should definitely keep fall into a couple of main categories. So for instance, there are physical issues, QIs around pain, breathlessness, constipation, falls, and so on. Other QIs that fall into more the psychological or the social domain, like loneliness and symptoms of depression or negative mood. And then there's a couple I've put into this other category. So for instance, there's an indicator, does the caregiver feel distressed, angry, or depressed? There was clear consensus to keep that. Also an indicator around how often is that person going to the hospital. So 20 of them, clear, everybody feels the same, very, very strong kind of consensus from people. And then there's another group of 7 QIs. I think I have most of them here. And these tended to fall in the, what I would call the psychosocial well-being domain. So these are QIs around, does the person struggle with the meaning of life? Is there a lack of progress towards completing goals from the person's point of view? Does the person express a wish to die now? Are they having anxious complaints, symptoms of anxiety? Others looked at sort of people's health, and again, there's a QI around a lack of completion of things like financial responsibilities or legal responsibilities. And for this group of QIs, people were less clear. So we're going to have a meeting next week, our entire team, to talk about what are the next steps in terms of this process. Do we need to go back and talk to people some more? Do we need to analyze the data a bit more? What are the next steps in terms of trying to come up with, okay, what is our list of QIs? So even though we haven't decided definitively, I wanted to show you and just give you a little bit of a taste of some of the things that we can do. So we had started doing some of this work for one of the projects that I'm on, looking at people with cancer and without. And again, these are not adjusted in any way, which means we have to be a little bit careful when we're comparing across different regions. But for this example, we're not comparing, BC to Ontario, so it's probably okay that they're unadjusted. And essentially what we see here is a bit of a pattern for some of these QIs where there is a higher rate. And in this case, higher always means worse because of the way that they're worded. So in the non-cancer group, they were more likely to have falls, to have a caregiver that felt distressed, or to report the person to report that they felt lonely. For the other QIs, we don't really see much of a difference. There's quite a similarity between the percent of individuals with cancer and non-cancer having those QIs. So then I thought, what would be very interesting for today is just to show you a couple of them across Canada. Now, this is where we have to take this with a grain of salt because we haven't done any risk adjustment. And it's possible that it has something to do not with quality of care, but something to do with the individuals being served in those provinces. We know that home care programs, these are all home care clients with cancer. We know that home care programs sometimes serve different populations. They have slightly different criteria for who's eligible and so on. So I just wanted to give you a bit of a taste of what we can do with these data. These are not in any way the final numbers. So we can't look at the 38% in British Columbia and say they're just doing a much worse job in terms of the caregiver feeling distressed than Nova Scotia. That would be inappropriate at this point. This is just kind of food for thought. And this is one of the ways, I think, maybe one of the most important ways that the QIs can be useful, is to start asking some questions about, well, what is happening in Alberta and Nova Scotia? Is there something they're doing? How is it that their rates are so much lower than what we see in Ontario and British Columbia? Once we do the risk adjustment, some of those differences might go away or be a little bit less of a difference. We don't know that yet, but I thought you might be interested just to see some of what we can do. And then we also looked at, I just picked out a couple of them, given the nature of the timing. This one is about loneliness, and this one is self-reported. So this is the client themselves, the home care client, is reporting that they're feeling lonely. The interesting thing here, this is one of the reasons why I chose these two, is now Ontario and British Columbia are not the worst. Now it looks like Alberta has the highest rate, which is very, very common with these kinds of indicators. We see this all the time, where any particular group, in this case, a province, but it also can be true at the health region level. People seem a little bit better on some things and a little bit worse on some other things, and that's just the nature of quality indicators and what you see. And again, what is happening in Nova Scotia and Manitoba in terms of loneliness? Is there something they're doing? Is there some intervention they have put in place, some program they have tried out to reach out to individuals to try and support them in a way that's helping people to feel less lonely? The QIs can serve as that sort of springboard to start the conversation, to look at what's happening, both sort of internally and looking around at other places to see what they're doing, and maybe try and understand a bit why you see the different rates that you do. So what's next for us? So we've got another year at least in this project. We need to decide on what that preliminary list of quality indicators is going to be. We've got that list of 27. We need to make a decision about which of those will we definitely keep kind of moving forward. And of those ones that we decide to keep, then we have to start to develop the risk adjustment. This is a tricky part. This was actually my PhD topic for my dissertation. The risk adjustment is a way to level the playing field so that you can compare BC to Ontario to Nova Scotia, and you don't have to be as concerned about the different types of clients that they serve. It demands that you have lots of data, which we have, which is good. It requires that you get input from clinicians. It requires that you sort of go through this back and forth process with people of showing them the risk adjustment, doing some statistics, analyzing some data, and coming back to those experts. So it can be quite labor intensive to get it right, and we definitely want to make sure that we get it right. We're going to continue on with creating some peer-reviewed publications. As I mentioned, we've got one in the works to summarize the workshop. We have one that's going to summarize the interviews and the focus groups. And in fact, it's being presented, the qualitative information is being presented next week at Hospice Palliative Care Ontario. They are doing a virtual conference next week, so we're going to be showing a virtual poster of those results, which is kind of cool. And we'll be obviously presenting the material at some other conferences as time goes by and as we start to be having conferences in person again or virtually for the next little while, as a way to sort of share the information, much like I'm doing today. So I would just thank you very much for your attention, and I'll be happy to entertain any questions.
Great, thank you very much. Maybe what I can do is get you to take down your presentation while
Sure.
People have a chance to type in any comments and questions that they might have in the chat box. And you might also be able to see the chat box as well. I see Jaquetta's put in a note to people. You can, at the bottom of your screen, click on the chat icon, and it'll come up on the right hand of your screen. So you can type your comments and questions in there. So perhaps while we're waiting for some comments and questions, I want to begin by thanking you for sharing the preliminary results of this study. It's very, very interesting. And I guess one question I had, and I don't know interRAI at all, so I'm coming from that space of this being an entirely new area for me, but you indicated that there were some of the themes or sub-themes could not be totally captured by the interRAI questions or data that's available, and it related to things like communication. And so I'm wondering if you might comment on how important those are and whether there are any proxy measures within interRAI data that might capture some of those things, or whether we need to consider adding assessment questions or whatever to interRAI.
Well, that's a fantastic question, and we sort of knew this right from the beginning, quite honestly, because if you look at the literature around palliative care and what's important to people, what's important to families, that dynamic within the team and how people relate to the team is important. And to get quality right, you need that good communication strategy. So we knew that we would probably be lacking in that area. I think we probably will, quite honestly, be taking some of this back to interRAI to say, here are some very important things people have pointed out. We can't capture them. Should we have some additional items? The difficulty always is that people want more on the assessment, but then it becomes too long. So there's always this balancing act of getting the right level of detail so that you are capturing all the important things without having an assessment that takes you 3 hours to complete. But we've already seen in the qualitative interviews some issues that I am already, the wheels are sort of turning in terms of going back to interRAI to bring that forward, which we do all the time. There's a separate group within interRAI that reviews all the instruments, quality indicators, any of the health scales that come out. As interRAI fellows, we can always bring forward ideas, and I can already see down the road there will be some instances where I'm going to have to sort of say, hey guys, I think we're missing some things here, and we've clearly heard from people that this is important.
Great, thank you. I see Barb Pessett has a comment in the chat box, and I'll just read it out. Thank you very much for the great presentation and much needed work. I can hardly wait to see the final results, and I think she speaks for all of us. We are looking forward to the final results as well.
Joan, I do have a question.
Great, go ahead, Clara.
Hi, Dawn. This is so interesting. My background is in home care, so I actually have been trained on the CIHR in my previous life. So I'm familiar with what you're saying. One of the challenges with palliative care is people often have limited energy when they are dying, and you had mentioned that the length can be prohibitive. Have you done any thought or research into trying to keep it short or anything like that?
It's fascinating that you bring that up. People are going to think that I paid you money to ask that. I didn't. So we are, as we speak, when I take off my kind of Laurier hat and I put on my interRAI hat, we are in the process of creating a palliative care supplement to the home care instrument.
Okay.
And this really came out of responding to what's happening in Ontario. So in Ontario, they started out years ago, and they still use the home care tool. Then if they have a client who's deemed to be palliative, they stop using that one and they start using the palliative care tool.
Yeah.
But they're both about 300 items.
Yeah.
And if they've got the home care data, they're telling us, but why do I need to do this whole thing? I've already got almost half of it. So we said, okay, let us make something very small that can be a supplement to the home care assessment. So you do the home care assessment, and then when someone's palliative, you just ask this small number of items. We have just started that. In fact, we are supposed to have our first focus group next week in person in Richmond Hill, which has been canceled because of the virus. So we're scrambling to try and set up, because we need clinical input. We need people to help us. I'm like, fine, I'm happy to create something that will work for you guys, but you have to help us. Tell me, what are those things you absolutely want to have? And then I will bring forward something to interRAI to say, here's a very short assessment. These are the key things. A lot of these things we're asking when someone's palliative and very seriously ill, you don't need to know all these things. They're not relevant anymore. So we're literally, we got ethics approval about 3 months ago. So we're just on the.
Okay. Good. That's interesting. And it was interesting you said there's about a 50% overlap because at that point I did do the CIHR, and where we are here in Interior Health, the palliative care, home care, they don't do the CIHR on, they only do it on people who are considered long-term care. They don't do it on what we would call acute care clients. So that's going to be another challenge when you roll it out, is each region does things a little bit different. I'm also wondering if you have thought into standardized teaching, because that's one of the challenges with the tool is how does the clinician interpret it and ask the questions to get the same data across your sample?
Yeah, so the group in Ottawa, the Canadian Institute for Health Information, together with John Hurdy's at University of Waterloo, have really been the group who sort of take on the education piece. And everyone who decides, any jurisdiction, province, region, decides to implement an interRAI tool, there must be a standardized training approach that follows what's in the manual. Everything sort of hinges on that. So that, you know, when I show you a rate for Alberta, we don't have to worry that people in Alberta are coding pain slightly differently than people in Ontario.
Yeah.
But it all hinges on that standardized assessment with the standardized training behind it. So everybody coding a 1 knows what a 1 means, and it's how do I know a 1 versus a 2? All of that comes into the education piece. Yeah.
Yeah. Thank you.
Welcome.
I have another question. And I encourage people online, if you have questions, just put them in the chat box. I'm wondering, the experts that looked at the quality indicators, I guess I'm looking at that link between the themes and the quality indicators and then the assessments. And I understand that it was experts involved in making the selections and then evaluating the indicators. I'm wondering if caregivers were involved in that process, would we have any different outcomes, do you think? I realize it's a bit kind of thinking probabilistically, but I guess I'm just wondering about the value of caregiver perspectives or even past caregiver perspectives in providing feedback on those quality indicators. And if that might have been helpful.
Yeah, well, I mean, those interviews with the caregivers have been incredible. I haven't read all of them. I read probably about 5 or 6 of the 20 interviews. Some of them are incredibly, they're gut-wrenching. The highs are high and the lows are low.
Mm-hmm.
Telling their story, talking about what they think is important. We opted not to ask the caregivers to do the Excel spreadsheet. It's a behemoth. We had multiple people come back and say, you know, this took me a lot of time to do. So we struggled a little bit at the beginning. Should we ask caregivers to do it? Should we ask patients to do it? And we opted not to, just because of the labor intensity of it. I think what would be really neat, and I've done this before in many different projects, where we sort of have this opportunity to circle back around to people a little bit closer to having a set of indicators, to go back to people and just sort of see, does this still resonate with you? You know, we developed these because we heard these kinds of things from people. Now that you see the list, you know, does anything in here seem strange? Is there anything missing? We haven't decided at this point if we'll do that, but we certainly have done that many times in the past. Just that last sort of check-in to make sure that we're on the right track. Because these things, they absolutely have to resonate with people. If people look at the list and they don't see things that are relevant, or they're like, I don't know why these people at Laurier came up with this, no one will use them, no one will want them, and that totally defeats the purpose. The whole idea is to give people something in real time, just with a click of a button. So we do need to keep checking back with people. So I'm not sure what that will look like in the end, but it is something we've done before.
Great, thank you. So do you think that, I mean, I can't help but ask this because in the current context of COVID, I'm wondering if your experts would be looking at these QI indicators any differently, you think?
Yeah, I don't know. My suspicion would probably be not, just in the sense that, what is important clinically is important. From a caregiver's point of view, from a clinician's point of view, or a decision maker, certainly there'll be a lot of considerations around resources and, where do we target scarce resources? The QIs can help with that, but they certainly can't tell you what to do. And so decision makers are going to be increasingly, not that they weren't, but increasingly in that tough position of trying to manage all of the needs of clients with limited resources, always scarce resources. I wish I had a bit more of a magic, wave the wand and here's how you fix things.
Yeah.
It's challenging for them now. It'll be challenging for a while. And I'm hopeful that the QIs will help people down the road. But I think we'll just have to wait and see.
Great. I see there's a comment. Can you speak a bit about the logistics of gathering this data when home care has generally been cut back and home care nurses seem to be busier than ever? It seems to me that the quality of data is going to be influenced by the logistics of gathering it.
Yeah, good question. My hope and my confidence is that it won't be. And I say this for a couple of reasons. One is that the whole point of the assessment itself is for care planning. Unfortunately, I've heard people talking about interRAI as a group and interRAI data for case mix and funding, which you can use it for some of those purposes. That's not what it was created for. The assessments are, number one, clinical assessment tools to help with care planning and service delivery. So as a clinician working in home care, I want to get it right. I absolutely want to make sure that I have the right data to support me in making my decisions. I'm going to have to make the decisions at the end of the day as the assessor, but this information can support me and I want to get it right. And also those data are going on to be used for other things. They're going to Canadian Institute for Health Information, who creates reports all the time using interRAI data from across Canada. They have one on palliative care, they have one on caregiving that are fairly recent. So I think people are doing their very best to get the assessments done and get the data collected in a way that truly does reflect that person, so that number one, the care plan is patient-centered. It absolutely is meeting the needs of that person and starts a conversation. Really, that's a big part of the assessment, is to start that conversation with the person about, okay, I see these various issues that I think are important for you to address. Where do you want to start? What's important to you? And we certainly have no evidence from a number of studies that the data aren't of high quality. There's a number of research projects that have gone on to check the data quality, and I think the multiple uses of the data by the individual assessor, by the health region, by CIHI, sort of reinforces that people try and get it right.
Great, thank you. Any further questions from you, Clara?
Hi, Joan. I do have one question. Going back to what you talked about, the 27 researchers or the 27 specialists, did you consider integrating any palliative care protocols, such the BC Centre for Palliative Care has standards for managing different symptoms at end of life, like constipation, pain, shortness of breath, anorexia? Did you bring any of that into your into what you're working on?
Yeah, to some extent, but mostly to identify those big kind of domain areas. So there's actually a lot of really good information across Canada, in the US, in the UK as well, of what are those key kind of things you should measure.
Right.
What we're not able to do in a lot of cases is bring in the once you've identified this issue, let's say constipation, there aren't interRAI data elements to say, now what did you do? That's not part of the assessment. It's part of the clinical note. It will certainly be documented, but we don't have multiple items to capture. Once you identify the thing, here are all the interventions and programs and treatments you put in place. We have a little bit on that, but that's really not sort of the goal of the assessment. So we looked at the literature, we looked at what people have been saying about, here's how you should manage these things well, here's what kind of quality measures they have in the US. But a lot of those quality metrics take it to the next step and say, here's what you should do, which ours don't. They just sort of say, here's how many people, here's the rate of this issue. Then you guys have to decide, how do we want to address it? Do we want to do something differently?
So it would, I'm going back in history a bit for myself. So it would trigger a CAPS. I can't remember what CAPS stands for. And
Clinical
then that
Assessment Protocol.
Right. And then that would indicate to the clinician providing the palliative care that they should be looking at that.
Right.
Quality indicator. Okay.
Yeah, so just to sort of compare and contrast, so that would be for the individual. So within the assessment, you get these flags or triggers that come out. You get a report that says, okay, for this person, they're at risk of, or they're experiencing these kinds of things.
Okay.
So the QI is similar in the sense that it flags what are the issues, but not for a person. For a group of people.
Okay.
Yeah.
Interesting. Okay, so that has a lot, the ramifications of your work are quite large then in influencing how palliative care is tested, and how it's rolled out, so we can tell, are we doing a good job on a big level?
Right.
I'm talking with my hands here.
Yeah.
Yeah.
Yeah. And we haven't done it yet, but I mean, New Zealand has mandated the interRAI home care tool and the palliative care tool. Now, I'm in contact with them all the time because they're one of the only countries, I think actually they're the only country that has mandated the PC across the country.
Okay.
They only have about 700 assessments now.
Yeah.
I'm on a team of people. We just got a paper accepted a few days ago looking at people. There's one item on the assessment that says person wishes to die now. So we did some research with the New Zealand PC data. They're coming. I mean, it's going to take them a while till they have like what we have in Ontario, but it's very exciting to see what's happening in New Zealand. Yeah.
Interesting. And historically, New Zealand has led the way in many areas of healthcare. If you think about cultural sensitivity, anyways. Yeah.
Well, this seems like a good place to pause. There's one more question. We might have time for it. It's also from Barb Pessett. I was really struck by the QI rate difference for non-cancer groups. Do you have any thoughts about why non-cancer rates are so much higher?
Yeah, that's a great question. And we have certainly talked about that in our group. So in that non-cancer group, who do we have? We have quite a number of people that have Alzheimer's disease, other related dementias, heart failure, COPD, diabetes, and so on. So I think for some of those indicators, especially around, say, falls, it would be a reflection of a frail elderly group, whereas we do see in the cancer group, they're younger. Mm-hmm. Typical home care clients without cancer might be, in their 80s, early 80s. The cancer group tends to be more average age of, sort of 50, 52 in that. So for some of them, I think that's what we're seeing, is that you've got some people with cognitive challenges and older people with multiple comorbidities, and so they're at risk for some of those outcomes.
Right. Well, this has been really fascinating to hear about this research and looking to the future, the possibilities for your findings from this work. So as others who've joined us today, we're really looking forward to hearing updates as the project unfolds, both and the implications for here, but also around the world. So thank you for joining us today and sharing these preliminary results with us, very timely. And I want to thank everyone who joined us online today as well. And this session has been recorded and will be located on the Institute for Healthy Living Chronic Disease Prevention website. So if you know of colleagues who might have missed it and want to catch it, it's still possible. So with that, I want to thank you again, Dawn, for joining us and for your presentation today, and to Clara as well for co-hosting our webinar today. So thank you very, very much.
My pleasure.
Bye-bye.
Bye.
Thank you, Dawn. Bye.
You're welcome.